introduce to you our presenter today, Mary Ellen Harris, a graduate of the Heritage College 3-year RN diploma program in 2000. Mary Ellen began her career immediately at the Ottawa Hospital, and then working through to medical and surgical floors, and later transitioned out of the city and joined RVH, where she gained extensive experience working as a night float nurse across the medical and surgical units, as well as the emergency department and dialysis, including those satellite units. In 2011, Mary Ellen went into management, joining which is now the Mississippi River Health Alliance, where she held roles as RNAO coordinator and assistant director, manager of complex continuing care, along with the intern leadership opportunities. Over the years, Mary Ellen strengthened her experience and in leadership, as well as nursing degrees. In 2016, her career advanced to the role of Chief Nursing Executive and Director of Patient Care Services at St. Francis Memorial Hospital. In 2023, she returned to RVH, where she continually serves in her present role. Over the 2 years, Mary Ellen also completed her MBA with a focus on human resources. Mary Ellen has been married for 24 years and has 4 children, 3 of whom are young adults, with the youngest of 12. She and her family have lived in the Beachburg area for 22 years, demonstrating long-term experience with the community. Now that her formal studies are complete, for now, Mary Ellen says she has shifted her focus to personal projects and home renovations, much to the dismay, Mary Ellen says, as her husband, Scott. Mary Ellen, what an incredibly impressive bio you have. One of clinical frontline experience, of continual education, and then now into such leadership roles where you're really going to be talking to us more about evidence-based practice and how you are putting that into practice in those that you lead. So thank you so much for being here and for that wonderful bio. I will hand it over to you.
Thank you very much. There we go. Is that looking okay? Great. All right. Thanks, everybody, for joining today. I'm really excited to present to everyone today about the SFMH, St. Francis Memorial Hospital in Barry's Bay, Ontario's journey with implementation of our CAM tool. So in terms of our organizational context and clinical lead as a small rural hospital, we undertook the change initiative within the broader context of implementing the best practice guideline for dementia, depression, and delirium. These 3 interrelated conditions represent a significant source of patient risk in acute care environments, and particularly among older adults and those with medically complex populations, and that is a significant population that we serve within our inpatient beds. And early identification of delirium really was a missed opportunity at SFMH, and we realized the delirium obviously was associated with increased length of stay, higher rates of falls, functional decline, and distress for patients and families. So importantly, this initiative was framed not as an additional task, but as a core component of people-centered care, emphasizing the responsibility of nurses to identify cognitive changes early on in the journey and respond proactively by situating the change within the organizational priorities for quality, safety, and patient experience. The initiative gained legitimacy as well as urgency. And this context helped staff understand that CAM completion on admission was not was not optional, but rather a meaningful practice change directly connected to improved outcomes for patients, families, and the healthcare system as a whole. Meaning we were not task focused in terms of the implementation of the tool itself, which was key. In terms of people-centered care and patient safety imperatives, by standardizing the CAM completion on admission, the nursing department positioned itself to address these risks proactively rather than reactively. This shift reflected a broader safety culture that values prevention, early recognition, and shared accountability. These values were framing the CAM tool implementation as a patient safety intervention rather than a documentation requirement, helping staff connect their daily practice to tangible outcomes. And all of us as nurses and healthcare providers recognize that buy-in is significantly increased when we can make those connections for frontline staff and practitioners. Nurses were encouraged to see CAM completion as an act of advocacy for vulnerable patients who may not be able to articulate their own needs. We also found it to be imperative that we reinforce the ethical rationale for consistent CAM use as it related to people-centered care. Ensuring that local practice reflected current evidence and professional standards was very key. This helped us to reinforce credibility of the initiative overall. Our work was often linked in discussions and education sessions, etc., at launch related to accreditation, quality improvement indicators, and external reporting requirements. Staff were able to see how their individual actions contributed to a broader system impact and overall goals. The CAM completion as a standard of professional nursing practice was the language that we used in terms of engaging frontline staff. We didn't discuss it as a tool in isolation, but rather as a best practice, which meant that we weren't focused on the task, but rather on continuous improvement of practice and standardization. So change planning and design. This is just taking us into looking a little bit at early engagement of frontline staff. And early engagement also meant that it needed to be meaningful to ensure success. So nurses needed to be involved from the outset to identify existing gaps in the admission process. So their engagement really helped us to understand where changes made sense in terms of their workflow, as well as improving overall outcomes for our patients and their families. And they were able to share practical insights into workflow realities. So as opposed to a top-down directive coming from leaders, staff were involved and invited to dialogue to discuss the barriers, concerns, and potential solutions. Frontline nurses acted as informal champions, so modeling the CAM use and reinforcing expectations among their peers. Change management best practices were employed, and transparency was certainly a key driver of success. Identifying gaps and opportunities for prevention. So this allowed leaders to address misconceptions, such as the belief that delirium assessment was only relevant for certain patient populations. Instead, the CAM was positioned as a universal screening tool, supporting equitable and consistent care, and continually drawing it back to evidence-based practice and continuous quality improvement. We did employ a phased approach, and it was important in terms of change management to understand workflows, identify the challenges, and make adjustments before normalization. So we were taking feedback as we went in terms of the implementation, and then adjusting as we go. This helped us to stay focused and ensure that staff were not approaching the change as an additional task. And we were constantly reinforcing it as a culture of continuous quality improvement. This meant that we weren't forcing it to fit in one particular part of the workflow, but rather nurses were empowered to decide where it made the most sense. And this autonomy allows for sustainability in the practice. Our implementation strategies were very much focused on education, which included brief huddles, just-in-time support, communication, visibility, and leadership presence was very key. And leadership needed to be the ones to help celebrate quick wins and staff recognition. So it wasn't focused on perfection, but rather on progress. I just meant to add that just-in-time reminders were embedded into our daily practice. And nurses really, as we all know, we respond and understand and learn when we understand the rationale for doing something, and this increased buy-in across the organization. It was important to highlight why it mattered, linking assessment results to clinical decision-making. So ongoing leadership communication, leadership visibility and effective communication was really key. This visible support of leadership really demonstrated commitment. It was meaningful for the staff to see and learn from each other and understand that leaders were respecting the fact that change is hard, but ultimately very worthwhile. Celebrating quick wins, again, not being focused on whether or not our performance was exceptional or perfect, but rather celebrating progress in a positive way. So recognizing and reinforcing positive behaviors. Progress was valued. And we even had some friendly competition taking place across the unit, which is also very healthy and helped to sustain practice and engage others and increase our buy-in overall. So in terms of how we monitored our implementation, how engagement and learning, it really was driven mainly by targeted audits, getting feedback and actioning things readily where we could, and holding people accountable. So stakeholder and PFAC engagement, lessons learned from the change process was important to be sharing back with our teams. PFAC being our Patient Family Advisory Council members. So targeted audits were used to monitor our CAM completion rates and assess adoption. Audit results were shared with the staff. This is where some of the competition started, and demonstrating progress overall really strengthened the confidence and commitment of team members. Engagement within the hospital certainly extended beyond our nursing staff and our frontline teams to include leadership as well as I mentioned before, our Patient and Family Advisory Council members. Their involvement helped shape the patient and family education materials that were used and are shared and are currently embedded into our admission packages. And it ensured clarity and relevance overall. And it was really important to help staff to see the connections between patient expectations, patient experience, and clinical practice. Lessons learned from the change process. There's always lots of those. So several lessons emerged from the initiative, including the value of early engagement. So consistent communication, having the teams be involved in linking practice to meaningful outcomes. Understanding this rationale was very significant in the process, emphasizing that successful change is relational, it's iterative, and it's grounded in shared purpose. Sustainability and outcomes. So embedding the CAM into standard practice, reinforcing the role of leadership and ongoing engagement, really measuring outcomes and impact on patient care, helped our initiative and implementation overall. And in order to sustain our practice change, we embedded the CAM completion into every admission process, so it became part of admission standards and documentation expectations. We're continuing to perform ongoing audits and provide real-time feedback. So it now is knitted into a routine quality monitoring practice, ensuring continued visibility. We also integrated education into our nursing onboarding process, where there is a day of education that is strictly focused on the onboarding of nursing staff. So it's part of that day, supporting consistency as new staff join the organization. And again, just reinforcing the role of leadership presence and the engagement of our PFAC members. This was identified as critical to sustaining focus on people-centered care and people-centered outcomes, linking practice to evidence-based outcomes. So leaders play a key role in reinforcing expectations, modeling these priorities, and responding to emerging challenges. The sustained engagement overall helps to prevent practice drift and maintains alignment with organizational values. And connecting those dots continuously with staff is really, really important to sustain a practice change of this nature. And overall outcomes and impact on patient care. So the adoption again of the CAM tool was on admission. It's now a sustained nursing practice at SFMH. Improved completion rates demonstrate successful normalization of the change, and most importantly, early identification of delirium supports prevention of harm, improved patient and family experiences, and strengthened people-centered care. Our PFAC members helped us to develop some education materials for patients, families, and caregivers to understand how delirium can be prevented and what types of things may put them at higher risk of developing a delirium, especially during hospitalization. So the initiative illustrated how thoughtful change management can translate evidence into everyday practice with a lasting impact. Okay, and that's it for my slides.
Wow, that was amazing. Thank you so much for taking us through the implementation of the CAM tool. I really, really like how when you really started by asking the staff, the gaps that they were seeing and the ideas that they had. And then your sustainability, just that how you were sustaining that within policy and education sessions and stuff. That was truly amazing, and all those steps are much needed to ensure, right, that this is going to roll out and be sustainable within your organization. So thank you so much for that. We can all learn definitely from the success of the implementation of the CAM tool and the success of your team. We are going to open it up to questions at this time. If anybody wants to raise their hand